And we probably will wait a few more minutes for more people to join in, and then I'll start the introduction. Okay, so good morning, everyone. Welcome to our PBR, the Pioneer in Biomedical Seminar Research Seminar Series. It's a great pleasure for me to introduce today's speaker, Dr. Johnson. Dr. Johnson got his PhD, MD, sorry, his MD from UAB in 2008. He then completed his internal medicine residency at Duke in 2011, and his hematology oncology fellowship at Vanderbilt. He then became assistant professor of medicine at Vanderbilt in the division of hematology oncology. He is now an associate professor of medicine at the Vanderbilt Medical Center. In addition to his academic position, Dr. Johnson has also taken many leading positions. For example, he's director of melanoma program at the Vanderbilt Medical Center, a co-director of Vanderbilt program for optimizing immune oncology therapy, co-director of cellular therapy and toxicity clinical trials, and associate director of precision oncology at the Vanderbilt Ingram Cancer Center. He is also co-leader of VICC Translational Research and Interventional Oncology Program, and recently he got the Susan and Luke Simons Endowed Director of Melanoma. So Dr. Johnson also received numerous awards, which I'm not going to go through all of them. Just list some of most recent ones. For example, he in 2019 he won ASCI Young Physician Scientist Award, and this year he got Susan and Luke Simons Endowed Directorship in Melanoma and the Vanderbilt University Chancellor Research Award. Dr. Johnson also served as on many national and international committees. For example, he is currently a member of NCCN Melanoma Guideline Committee, and he also was served as a chair of American Society of Clinical Oncology annual meeting, the Scientific Program Committee, Melanoma and Skin Cancer. Dr. Johnson is currently a steering committee member of Melanoma Research Foundation Breakthrough Consortium. He also serves in as editorial board of several scientific journals, also scientific advisory board of many big pharmas such as Merck, Pfizer, and Novartis. As a clinical doctor, Dr. Johnson also is heavily involved in research. He is currently a PI, or co-I on multiple NIH R01s and the Melanoma Research Foundation grant. Dr. Johnson is also very productive in research. Since 2011, Dr. Johnson has published 154 research articles and 91 reviews and editorials. He is also involved in 19 different clinical trials. So Dr. Johnson leads the melanoma clinical research program at Vanderbilt. His research mainly focuses on new immunotherapies and targeted therapy for melanoma. His lab is exploring new biomarkers that allow oncologists to predict which patients will benefit from immunotherapy. He is also interested in understanding the effectiveness and the toxicities of immunotherapy in high-risk melanoma including those with autoimmune disorders or organ dysfunctions. Dr. Fralin actually sent us a movie clip called Breakthrough, which introduces Nobel laureate Jim Allison, who discovered the power of immune cells as cancer therapies, those so-called immunotherapies. So today, our speaker, Dr. Johnson, will also talk about this breakthrough, and the title of his talk is Dissecting Toxicity of Immune Checkpoint Inhibitors. So without further ado, please join me to welcome Dr. Johnson.
Well, thanks for the too kind introduction. Let's see, I'm pulling up my PowerPoint here. Sorry, it was up just a second ago. There we go. Okay. All right, there we go. So thanks again for the very kind introduction and the invitation to join you today. I apologize. There just started some construction or yard work right outside my house, so please stop me if it's distracting or there's background noise. So let me know. But today I'd like to talk to you a little bit, which I hope will be something for everyone, thinking about toxicities of immune checkpoint inhibitors. And this is really a bedside to bench and back kind of a story. So hopefully people who are interested in the more clinical side, translational side, and basic science side will have something of interest here. These are my disclosures. So again, I'm going to talk a little bit today about toxicities, the autoimmune-like toxicities of immune checkpoint inhibitors, which have really been transformational therapies in cancer. And again, we'll start at the bedside and go back towards the bench. So when I talk about immune checkpoint inhibitors, I think it's just important to quickly talk about what I mean by that. So really, there's two major classes of immune checkpoint inhibitors that are approved for patients with cancer. So these therapies are, you can see in the middle are CTLA-4 inhibitors, which is really, there's only one approved agent, ipilimumab. And then on the right, there are PD-1 and PD-L1 inhibitors, which there's several approved. Actually, that number is even larger than when this was written. But these work at different points in the immune activation process. So the CTLA-4 inhibitors work really when T cells encounter antigen-presenting cells sort of early in the immune priming process. And they remove this negative regulator that allows the T cells to be activated, and in this case, a bit more non-specifically in the case of CTLA-4 inhibitors. On the other hand, the PD-1 and PD-L1 inhibitors function really more at the level of the tumor microenvironment, or as you can see, they're also perhaps with other sites of end organ damage and so forth. But they really function at the level where T cells are actively present in the tumor microenvironment. They recognize the cancer, they're poised to eliminate the cancer, but really you have this one last molecular interaction between PD-1 and PD-L1 that dampen the T cell response and don't allow the T cells to be activated. And so blocking that with an antibody to either PD-1 or PD-L1 will then allow the T cells to activate and eliminate the tumor. So I don't have a slide on this, but I guess just to take a step back and think about how these therapies have impacted cancer therapy. So I'll just give you one quick statistic. So 10 years ago, the survival for metastatic melanoma, which is the kind of cancer I treat in the clinic, basically patients had a 0% long-term survival rate. There was a random patient that might have responded to chemotherapy and done well, but essentially it was a 0% long-term survival rate. With combination immunotherapy now, with the combination of PD-1 and CTLA-4 blockade, as we'll talk about more in a minute, patients now have a 50%, so half of patients are having long-term survival. And we're seeing these long-term responses caused by the immune system and caused by these immune therapies in a whole variety of tumor types. Now, unfortunately, they're not usually as high as 50% in most cancer types, but we're seeing this across a huge swath of cancer types, and these are now approved in about 20 different types of cancer. So we're seeing this in kidney cancer, lung cancer, bladder, a whole variety of cancer types. So these have really transformed the way we treat cancer really just over the last few years, and this is something that as was mentioned, was something that resulted in the Nobel Prize just a couple of years ago. Okay, so back to the sidebar over. So back to the talk. So like I said, this is great when PD-1 blockade works as advertised and eliminates and causes the T cells to be activated, resulting in tumor cell death and tumor elimination. And here's just one example of a patient from my clinic. So this is a patient, a PET scan on the left before treatment, where the patient had a softball-sized mass in his right lower lung. This patient also had a 4-centimeter mass in his right ventricle and his heart. And in fact, just a few months into treatment, these tumors had melted away. In fact, the patient had an echocardiogram or an ultrasound of his heart a few weeks into therapy, and the tumor was already gone. So these therapies can cause not only durable responses, but actually very quick responses too in patients with metastatic cancer. And it can really be remarkable to see this in the clinic. Now, unfortunately, the hypothetical question here would become, what happens if you have sites of organ inflammation? So, and especially what happens if you block multiple negative regulators of immune function? So again, these immune checkpoints that we're blocking are normally used in the physiologic setting to maintain immune homeostasis. So what happens if you block those, and instead of the target being the tumor, what happens if the target is our own organ tissues or our own cells? Can this result in organ cell death and organ elimination? Obviously, great when it's the tumor, not so great if it's your heart or another organ that's necessary for survival. Well, fortunately, the answer is usually that does not happen, but unfortunately, the answer is sometimes it does happen. So I'm going to talk quickly about a case that really got us interested in these immune therapy toxicities, these side effects that happen from immune therapies. And I'll just take you through the case quickly. So this is a 63-year-old woman that we treated in our clinic that had pretty widely disseminated metastatic melanoma. And she was treated with a combination of CTLA-4 and PD-1 blockade. And very early in her treatment course, just 12 days into treatment, developed pretty non-specific symptoms, chest pain, shortness of breath, for a couple of days and came to the emergency department. And for those of you who aren't familiar with these laboratory values, the patient had very abnormal troponin levels, which is a marker of cardiac injury and cardiac damage, and elevated CPK or creatinine kinase levels, which indicates muscle injury more non-specifically. And these are dramatically elevated. Normal, for example, in our place, normal for troponin is less than 0.1. So this is, almost 50 times the upper limit of normal. And so I'm guessing there's probably not too many cardiologists on the call, and I'm certainly not one myself. But the patient's EKG was quite concerning. So this is something called complete heart block, where some of you who have seen EKGs before might sort of recognize that these P waves, these little humps here, are completely divorced from these larger complexes, these QRS complexes. And so what this means is effectively the top part of the heart, the atria, are functioning completely independently from the ventricles. And this is, like I said, something called complete heart block. It indicates that the heart's electrical system is completely disrupted. And so this rapidly progressed, and the clinicians on the call on the webinar will see that this is a very concerning EKG. This is something we call a sine wave EKG, where the heart has basically gone into chaotic electrical activity. This is something called ventricular tachycardia, and it's essentially not compatible with life. So this shows the patient's treatment course. The patient, again, just started therapy, and 12 days into treatment, came into the hospital, and the patient's troponin level continued to rise despite treatment and starting on immunosuppression. Unfortunately, within 5 days, the patient had died of progressive and fulminant arrhythmias, where the heart electrical function just continued to deteriorate. Now, before I tell you, excuse me, more about this patient, I'll talk to you just very quickly about immunotherapy toxicities. So again, we're removing these negative regulators on the immune function. So these patients can develop these autoimmune-like syndromes. So the question is not so much what organs can be effective, it's almost which organs aren't effective, because they're almost all affected. Now, here are some of the common types of organs that are affected from these autoimmune-like toxicities: endocrine, especially thyroid, lungs, liver, colon, joints, and skin. Unfortunately, there's a whole range of rare toxicities too. So the brain, the eye, the heart, the pancreas, the stomach can all be affected by these immune checkpoint inhibitor toxicities. Now, these can be very challenging to diagnose because, obviously, as you can see, essentially all organs can be affected, and this can be, a minefield to diagnose clinically. But the good news is that this is all inflammatory. So from a clinical standpoint, we know that if we can mitigate the inflammation and sort of calm the immune system down, so to speak, then we can potentially improve the patient's clinical syndromes. Now, this patient had something called immune checkpoint inhibitor associated myocarditis, and we published these couple of cases about 5 years ago now in New England Journal of Medicine. It's one of the first times this has been sort of systematically that happened. Now, there were basically two patients that had very similar presentations that happened within about 2 weeks of each other, which I tell you was, made us all, gave us all a little bit of PTSD after that had happened. But there were these two cases that came in very similar presentations that had progressive arrhythmias that essentially sort of marched from first-degree heart block to second-degree heart block to third-degree heart block and had worsening arrhythmias over time. Interestingly, this is a little bit different than some forms of myocarditis, where the patient's ejection fraction, the squeeze function of the heart, was actually not affected. So the electrical system was affected, but not so much the pumping function of the heart. What was also very interesting to us is that the patients also had associated myositis. So the heart muscle was affected, but also the skeletal muscle was affected. And these patients both had very early onset, and of course both died. And so this was some slides from the autopsies of the patient. And what you could see is that these were CD8 positive cells that were all throughout the heart, as well as CD68. So these were CD8 T cells and macrophages that were sort of, just throughout the heart. And this was another very interesting slide to us. This is a slide from the patient's esophagus, whereas you can potentially see, or at least imagine, as I tell you, with the black arrow on the top left, this is a slide. This is the patient's smooth muscle, which essentially had no T cells or no immune cells in it. But on the bottom right is the patient's skeletal muscle, which, as you can potentially see, is essentially obliterated by this immune process that's attacking. So this was a very specific immune process to the muscles, to the striated muscles, the cardiac and skeletal muscle. Okay, so obviously, we're hoping to identify these patients and not have this happen again. But we were able to find a large pharmacovigilance database. So this is a database where, from the World Health Organization, where physicians and pharmacists and patients even can call in and report different types of drug reactions that happen after receiving some sort of treatment, including immune checkpoint inhibitors. And so we were able to find 101 patients that experienced this immune checkpoint inhibitor myocarditis. And we found that this occurred across men and women. It occurred across cancers, so this was not just patients with melanoma, even though the first two patients that we saw had melanoma. What was interesting to us, too, is that many of these patients didn't seem to have necessarily a cardiovascular history. So this was not just patients that had pre-existing heart failure or coronary artery disease or obvious other heart disease. This also happened very early on treatment. So again, we're talking about these kinds of therapies that can produce durable responses, and patients live very long, but these patients are experiencing these very severe toxicities just after starting therapy. And also, as the two patients that we had, there seemed to be a very high rate of concurrent skeletal muscle involvement. So again, not just the heart, but also the skeletal muscle. And some of the patients had very similar presentations to myasthenia gravis, which is an autoimmune neurologic condition. And these patients had very high fatality rates, with about half of patients in this database dying, and this was especially high with the patients who treated with combination immunotherapy. So very, very fulminant presentations. And this did seem to be expanding, and that certainly has continued to expand since then due to the increased use of immunotherapy across many, many patients. Okay, well, obviously this is enough to scare anyone from using immune checkpoint inhibitors. Now here's a little bit of good news. So this, thankfully, is a very, very rare toxicity with immune checkpoint inhibitors. In our original paper, we estimated it under 1%, and this is probably more because this was a less recognized syndrome at that point, and it was really kind of early days of immunotherapy use. If you sort of really systematically look for patients and screen their troponin levels and get EKGs, very common, you can potentially detect this in higher rates, but it's probably in the range of about 1% for patients treated with combination immunotherapy, and probably in the range of 0.3 to 0.5% for patients treated with single agent. So thankfully, most patients do not get this sort of fulminant toxicity. The treatment for this is very similar to treatment for other types of immune checkpoint inhibitor toxicities, and that's steroids. So unfortunately, it's not enough just to withdraw the treatment, because these therapies, have long half-lives and also have long pharmacokinetic and pharmacodynamic impact, where thankfully patients can respond long-term, but also the toxicities don't just go away overnight. And so we have to use something to actively suppress the immune system with something like steroids. And then probably for these very severe toxicities, we need additional agents. Now, one agent that we are very interested in full disclosure, there is a patent pending, which I'm one of the authors on for this particular agent. But one particular agent that we're interested in, this was a case report from one of my colleagues in France, who essentially had a patient that was with non-small cell lung cancer that came in, and the patient's troponin was increasing dramatically despite high doses of steroids, despite plasma exchange done to try to remove the antibody, and this patient was still continuing to get worse with increasing weakness, increasing arrhythmias, increasing troponins. And then the patient received abatacept, which is actually kind of the reverse of ipilimumab. It's actually a CTLA-4 fusion protein. So theoretically would restore CTLA-4 signaling and potentially reverse the effect of the immune checkpoint inhibitor on the heart. And as you can see, after the first dose, the troponin dropped precipitously, and the patient was able to leave the hospital a week or two later with essentially asymptomatic. So we think these kinds of agents may be interesting as rescue agents for patients that don't respond to steroids or have very severe toxicities. So we look to see, it's interesting to see whether, these rare patients have myocarditis, and that's certainly important to look at. We also wanted to see whether there was any signals for patients developing other cardiac complications. And what we found in these World Health Organization databases is there was a statistical association with pericarditis and vasculitis, which perhaps, maybe not surprising. These are inflammatory side effects. We did not see, and this is early days, but we did not see any association with things like myocardial infarctions or congestive heart failure. And I think these are really important questions that we'll have to learn more about going forward, because as these therapies proliferate more and patients have long-term survival, we really do want to learn how these affect other immune processes. Obviously, as probably some of you are working on, some of these processes like atherosclerosis and heart failure and hypertension do have some sort of immune component, and so understanding how long-term blockade of PD-1 and PD-L1 affect these immune processes is something that we really are only just beginning to get a handle on. So we wanted to look as well, we'd shown and others had shown that myocarditis causes high fatality rates, but we wanted to see, okay, how many patients are actually dying of these toxicities? Clearly, these therapies are causing long-term survival, but what's the magnitude of the problem for fatal toxicities? And so thankfully, we're able to find that, especially with single agent anti-PD-1, it's only about 1 out of 300 patients who are experiencing these fatal toxicities, maybe as high as 1 out of 80 for patients treated with combination immunotherapy. And there's a pretty wide variety of different causes that cause fatality. So you can see myocarditis and with the on the right there, we had the highest fatality rate approaching 50%. But things like pneumonitis, if the lungs become inflamed, that's obviously clinically pretty severe as well, and neurologic toxicities as well. And you can also see these toxicities are really increasing over time as patients are being treated more often with these therapies. And these fatal toxicities tend to occur very early, which I think is interesting pathophysiologically. Now, toxicities more globally have a pretty wide spectrum, so it's pretty unpredictable if, say, a patient gets a skin rash or a patient gets colitis. It really can kind of happen anytime during therapy. It does tend to happen, a couple months into therapy as sort of the peak time, but it's really a wide distribution. Well, one thing you can kind of see with the fatal toxicities, they do tend to cluster a bit more very early on therapy, which is, I think, potentially speaks to perhaps some of the pathophysiology here. Perhaps these patients have some sort of smoldering immune process going on in one of their organs. We were talking last night, maybe these patients have had, a viral myocarditis that's sort of partially improved or still perhaps even subclinically happening. And these patients receive checkpoint inhibitors, unleashes the immune response, and these patients have a fulminant reaction to checkpoint inhibitors. Now, patients can also die of other things as well with these therapies. So, this was a patient that I had in my clinic that was 77-year-old and had, very bad disease, had, tumors taking up about half of her liver, and really would have had a, incredibly poor prognosis previously. And she had a beautiful response to treatment, but unfortunately she developed colitis or inflammation of the colon, was treated with high-dose steroids. And then one thing led to another. The patient had steroids, and that led to atrial fibrillation that required an admission. And then she had hospital-acquired pneumonia, and then ultimately ended up dying of this cascade of different toxicities and side effects. So these therapies, these toxicities are non-trivial, even for patients that don't die directly of the toxicity. Now, I will say there is some more perspective if you think about actually what the burden of disease from, I'm talking a lot about toxicity, but I want to make sure that we know the magnitude of the problem. So this just sort of shows the hospitalization for toxicity versus the hospitalization for disease. This was a cohort of about 300 patients from our place. And as you can see, non-trivial numbers of hospitalizations from toxicity, but you can see in the red, the bulk of these patients are still suffering and dying. If they are suffering and dying and not responding, it's from their cancer. As you can see, again, the total days admitted, also more for disease. And then if you look at actual deaths, clearly, the vast majority of patients, if they die, it's going to be from cancer and not from toxicity. So as important as thinking about these toxicities are, we clearly need to, and we need to treat them and mitigate them. Clearly, the biggest issue is still the disease. Now, so one question I always get that patients ask and other doctors ask is, okay, what happens if a patient gets toxicity? Is this a good thing or is this a bad thing? Obviously, if a patient dies of toxicity, that's a bad thing. But what happens for sort of mild toxicities? Does this show that the patient has a competent immune system? Does this show that the patient might have a better likelihood of response? And so there is some data that suggests there's sort of been reproduced a number of times, including by our group and many others, that suggests that patients who have toxicities do better. Now, one issue of this is that there's a bit of a time bias. Patients who have longer therapy perhaps get more toxicity. And of course, patients who have longer therapy are more likely to be responding, because if they weren't responding, you would have stopped treatment. So there is some sort of time bias, but still, you can see patients who have very early toxicities in the top right there still have better survival than patients who don't have any toxicities at all. But that's certainly accentuated if you look at patients who have side effects after, say, 6 months. Those patients are going to do very well, because again, there's a reason they're still on therapy 6 months later, because they're probably responding. Now, the one potential exception to that are patients with very early severe toxicity. So this was a study that we were involved with one of the Australian groups, and these were patients who were treated with ipilimumab and nivolumab and received very early steroids, to blunt the immune response. Now, that's another big important question, is whether patients that you would think, okay, if you're giving high doses of steroids to blunt the autoimmune response, perhaps this is blunting the anti-tumor response too. And actually, that actually does not seem to hold up, except perhaps in this circumstance where patients get very early toxicities. So, the way I put it together perhaps is that these patients, need to establish an immune response against the tumor, and then steroids are not going to disrupt that. But if you give the steroids very early, perhaps that does disrupt the anti-tumor response. And you can see in this group of patients, the patients that had higher doses of steroids very early in the gray and the red seem to perhaps do worse than the patients who had either low doses or no steroids in the blue and the yellow. And this is another study that sort of showed that same thing, that was sort of a multinational effort. The patients who had early steroids in the black seemed to have inferior overall survival compared to those in the gray, which did not have early steroids. So another important type of toxicity that we've studied has been chronic toxicity. So it's important, obviously, if a patient dies of toxicity, but it's also important if a patient has very lingering side effects and toxicities from checkpoint inhibitors. And so there's been a number of studies that show that endocrine toxicities tend to be lifelong, because these patients require hormone replacement. So, for example, if the thyroid goes out from immune checkpoint inhibitors, that's probably not going to come back. The hormone-producing cells are probably all destroyed, and they're going to require long-term. And similarly, arthralgias tend to be long-term as well in many cases, where patients develop joint pain, and this can become a chronic, almost like a rheumatoid arthritis syndrome. And so we had recently looked at a group of patients treated with anti-PD-1 in the adjuvant setting. So it's hard to study chronic toxicities, because obviously a lot of patients unfortunately die of their disease. A lot of patients receive additional surgery, additional therapies. Kind of hard to dissect what's what. So we identified this group of patients that had high-risk melanoma that didn't have metastatic disease. So these are patients that don't have any active disease and are getting anti-PD-1 to try to prevent their cancer from coming back. And we found that actually 41% had some sort of chronic toxicity. So there does seem to be some sort of chronic inflammation or chronic complications that do happen with this. And this can be a whole variety, a spectrum of different phenotypes, including endocrine and rheumatoid, but also a whole wide range of other different types of toxicities. And this is one example. So these are patients that develop pneumonitis or lung inflammation from immune checkpoint inhibitors, which is a common and very clinically relevant. And you can see that the lung inflammation on the left, which was the initial pneumonitis, was certainly improved compared to the right, but these patients still did have some residual inflammation, and we don't know the clinical impact of that. It may be very minimal, but it may be some sort of may also be clinically relevant in terms of decreased lung function and exercise capacity and so forth. One of the big questions that we also always get is, can we predict which patients are going to get toxicities? Again, these are autoimmune-like toxicities, and so can we say ahead of time who's going to get this terrible myocarditis or other different kinds of side effects? And so, unfortunately, at this point, the answer still is not really. Now, we did this one study where we looked specifically at patients that had pre-existing autoimmune disease. So this is the patient you would expect to be boy, the highest risk of getting toxicities. And not surprisingly, these patients were all excluded from the original clinical trial. So if somebody had rheumatoid arthritis or psoriasis or lupus or any other types of autoimmune phenomenon. But actually, it turned out that many of these patients did really well with checkpoint inhibitors. A lot of them did have low-grade flares of their autoimmune disease, but they didn't seem to have any increased rate of other different types of side effects. And so we really kind of think of these patients, treat them with caution, but we don't withhold these potentially life-saving agents from patients with autoimmunity. And I think that highlights the problem of trying to predict which patients are going to have complications. If the patients you would think would be the absolute highest risk seem to generally do okay, how do we find something better? We've also found that patients generally with organ dysfunction do pretty well. So that, patients, for example, with chronic kidney disease, chronic liver disease, those patients also would have been excluded from clinical trials and from many other kinds of therapy. But it turns out they do reasonably well with checkpoint inhibitors as well. Now, the one group of patients, perhaps not surprisingly, that we are very concerned about giving checkpoint inhibitors to are patients with solid organ transplant. So, probably the PD-1, PD-L1 axis is very important for maintaining graft tolerance. And so many of these patients in sort of isolated anecdotal case reports really reject their graft if they're given anti-PD-1. If they develop, metastatic cancer that would theoretically be responsive to anti-PD-1, they often do respond, but they often also simultaneously reject the graft. And some of those patients can be salvaged with steroids, but some can't. And so, we're very cautious about giving these therapies to patients who have had organ transplants. This was another study we did to try to understand what are the correlates of toxicities. And one thing that was interesting to us was that there did seem to be a bit of an age spectrum. So patients that were older had a higher incidence of dermatitis and arthritis, and pneumonitis, and perhaps cardiac and muscle toxicities as well, whereas patients that were younger seemed to have a higher rate of GI and hepatic toxicity. So interesting findings there. Don't have any idea of the pathophysiology there, but it would be interesting to do additional studies to try to understand what's different in the tolerance mechanisms in the gut and the liver in younger patients compared to older patients. This was recapitulated not only in our data but in a pharmacovigilance study. Now, there's been a couple of interesting papers that suggest that patients who are obese actually have a better response to immune checkpoint inhibitors, which is sort of a potentially paradoxical finding, sort of termed the obesity paradox. For patients that perhaps this is related to some sort of inflammatory milieu in the obesity and the adiposity, but it's not really well explained exactly why this happens, and I would say it's not totally established finding either. So what we did was we looked at body composition, so looking not only at the BMI of the patient, but actually looking at the muscle and fat content using this software called Slice-o-matic, which I think kind of sounds like a 1950s toaster or something like that. But you can basically get the L3 vertebra and get a cross section there, and it'll delineate what's muscle and what's fat. And you can then associate. And so we really didn't see much association, honestly, either in terms of toxicity or response. There was a small trend towards better responses in patients that had high levels of muscle and high levels of fat compared to the patients that were, say, sarcopenic, which is low muscle content and low fat content. Interesting there, but not a clear association. Okay, for those of you keeping score in terms of the time, don't worry, that was the longest section. We've got. I'll sort of briefly go over some of these other studies that we've been working on, and we'll have some time for questions at the end. So unfortunately, we've learned quite a bit from autopsies from these patients who have unfortunately died of their toxicities. And so these are some slides from the original patient that I mentioned, the one that developed fatal checkpoint inhibitor myocarditis. And just to highlight the top left here, this is an H&E slide from the patient's myocardium, and normally heart muscle should look at sort of like this, what you can see at the top and bottom here, but you can just see this patient's heart muscle is just totally obliterated by this immune process. And so we actually took this heart muscle, from the autopsy from the patient, the heart muscle, the skeletal muscle, and the tumor from the patient, as well as we had a pretreatment tumor biopsy and did T-cell receptor sequencing to understand, was this a monoclonal process or more polyclonal? And one thing that we found in this first patient is that there were a number of shared clones in the pretreatment tumor and post-treatment tumor, pretreatment tumor in the heart, and that really expanded between the post-treatment tumor in the heart, and also a number of shared clones between the skeletal muscle and the heart muscle. And I think more interestingly to us was that in the second patient, unfortunately, that had a very similar presentation, is that we had this patient had a very high frequency clone that was really the highest prevalent in the heart was also very high in the skeletal muscle as well. And this same clone was present in the pre-treatment tumor and expanded in the post-treatment tumor. So this potentially suggests that there could be some sort of shared antigen where there's an antigen in the tumor that's being recognized by the immune system, and it's the same antigen in the heart. Obviously, this is very circumstantial evidence, doesn't prove anything. And so in conjunction with some of my colleagues from Vanderbilt, Justin Balco and Javid Moslehi, who are fantastic collaborators, we looked at RNA sequencing from these same tissues, from the tumor, the skeletal muscle, and the heart. And we found that there were high levels of interferon gamma signatures, not surprisingly, in all the tissues. And there were also, high levels of transcripts and things like myosin heavy chain, troponin, desmin, muscle-specific transcripts also in the tumor. So again, potentially some circumstantial evidence that there could be some sort of shared antigen going on. Again, very circumstantial, not mechanistic or causal. And the other case I'll briefly highlight quickly was one that we had published a couple of years ago with a patient with fatal encephalitis from checkpoint inhibitors. So this was a patient with metastatic melanoma who got pembrolizumab for 18 months and had a complete response, and unfortunately developed sort of an encephalitis picture. And so his MRI, you can see, for those of you who are familiar with looking at these, this patient had temporal lobe enhancement that looked for all the world like a viral encephalitis, and this progressed to bilateral involvement. And unfortunately, despite getting heavy-duty steroids and rituximab and other immunosuppressants, the patient died. And so you can see again here, just immune cells just all throughout the patient's temporal lobe region, CD4, CD8 positive T cells, PD-L1, high levels of expression there. And so one thing that was interesting here is we did, again, RNA sequencing on the patient, not only a normal temporal lobe control, but also from uninflamed region of the same patient's brain, and then from an inflamed region, as well as from 3 patients that had encephalitis that was not related to immune checkpoint inhibitor. And so you can see there's a number of potential differences here. But one thing just to quickly highlight is this population of memory-activated CD4 cells that was really seemed to be unique to the population, to the patient's this checkpoint inhibitor encephalitis patient. Now, we also did, I'll come back to that population in a second, we also did T-cell receptor sequencing in these patients, and what we found was quite fascinating is that there was a large number, basically about 20% of the patient's T-cell receptors were known to be specific to Epstein-Barr virus. And then there was also this really high clone, almost 20% of the patient's T-cells were specific to this clone right here. And for people who know these things, not which doesn't include me, is that this had a very high degree of homology to other Epstein-Barr and other viral specific PCR sequences. So potentially suggesting there could be a viral role for this checkpoint inhibitor toxicity. And so what we did was we did a base scope to look at this particular T cell receptor sequencing, and we actually found that it co-localized not to a CD8 T cell, but to a CD4 T cell, which is a little bit surprising to us as we kind of think of, at least my simple clinician mind, I tend to think of CD8 T cells and toxicities, but really this seemed to be localized to a CD4. And also these same CD4 cells also had high levels of granzyme B and P67, so really suggesting they were actively proliferating and cytotoxic, which is interesting because, again, these are CD4 T cells, so suggesting this might be a cytotoxic CD4 cell. And then, again, these known Epstein-Barr TCRs were on CD8 T cells and also active and proliferating and present as well. So in the last little bit of time, we've got a few minutes left, so I'll talk a little bit about some of the basic science studies that we're doing with checkpoint inhibitor toxicities. And I'm very much in a support role, and if I say something ignorant, it's probably because I am not a basic scientist. But this is something that our group is really interested in and working on. Now, this was one of the first studies that we've been working on. This was a mouse model that was developed in conjunction with my colleague Javid Moslehi, as well as Jim Allison from MD Anderson, who was mentioned earlier, but the Nobel Prize winner for discovering CTLA, or for characterizing CTLA-4. And so what was interesting in Dr. Allison's, his lab's hands, is that what they did was they knocked out the gene encoding PD-1 and the gene encoding CTLA-4 in mice. And so, unsurprisingly, in these yellow and green lines, if you knock out the gene, both copies of the gene of CTLA-4, these mice die, sort of irrespective of what you do with PD-1. And that's been well described, these mice, patient-focused, these are mice. if you knock out both of these copies, these mice develop very early, fulminant autoimmunity and lymphoproliferation. These mice die very early. On the other hand, if you knock out PD-1, these mice do okay. Really, sort of no problems. If you knock out one copy, if you knock out both copies, they all do fine. But there's this interesting phenotype here in the red. If you knock out both copies of PD-1 and one copy of CTLA-4, about half of the mice die. And this, we recapitulated this in our hands as well, or in my colleague Javed Moslehi's hands as well, where you see in the blue and red here, if you knock out, again, the same, one copy of CTLA-4 and one copy, or both copies of PD-1, you see increased, these mice die. And this was certainly dramatically more severe in actually in female mice, which is interesting. So we looked at the hearts of these mice, and it turns out that these mice are dying of myocarditis, very similar to what we observe in patients. And it's a very similar phenotype too. They have preserved ejection fraction, so the pumping function of the mice's heart is unaffected, but they develop massively inflamed hearts and arrhythmias. And so you can see these hearts are in these knockout mice are CD8 T cell enriched. And what was interesting to us is if you give abatacept, which again I mentioned earlier in the talk, CTLA-4 fusion protein, this actually rescues the phenotype, and these mice don't die. And then it also it decreases the cardiac inflammation in these mice as well, especially not so much early on, but over time it decreases. So to look at this further, so that they published their findings in Cancer Discovery early this year. And to look further, my colleague Justin Balco and his postdoc Maggie Axelrod has done some single cell sequencing in these mice and compared them with healthy wild type control mice. And so what she found was that these mice, the mice with myocarditis, have unsurprisingly a very different cellular profile. And really this is primarily around the activated T cell compartment where these mice essentially the control mice don't have any activated T cells in the heart, which is probably a good thing that neither mice nor humans have tons of T cells in the heart, but the mice with myocarditis have a significant amount of T cells. And then if you look at these further with RNA-seq, the different gene patterns, it's certainly a lot of our sort of normal favorite players as far as interferon gamma signatures, chemokines, et cetera, are enriched in the myocarditis T cells compared to the control T cells. Now, these T cells in the heart are also clonal, as you can sort of see at the bottom right here. There's a lot of clonal myocarditis cells, and these clonal T cells do tend to be CD8 T cells, which is again different from the encephalitis patients that we saw. These seem to be a very clonal CD8-driven process. And then if you transfer the CD8 T cells from the affected mice to RAG1 knockout mice, you actually get an interesting phenotype. And then do TCR sequencing on the cardiac tissue, you get an interesting phenotype where these mice also develop myocarditis. So again, transfer from the affected mice to these RAG1 knockout control mice, you get myocarditis. And then what's interesting to us is that this is the donor mouse that had myocarditis. And you can see there's one T cell that's dramatically causing or at least making up the infiltrate of the myocarditis. But it's interesting that T cell becomes the dominant clone in two of the mice, but then there's a totally different low frequency T cell clone that becomes the dominant clone in another mouse. So currently a number of studies ongoing to try to understand what's the antigen here. I alluded to this earlier. Could there be a viral cause trigger? Could there be a shared antigen between tumor and affected tissue? There's a number of studies ongoing now to try to do antigen discovery and understand what's the affected protein that's being targeted by the immune system for these very severe cases. So to kind of wrap up and leave plenty of time for questions, there's a number of insights that I think that we can get from both preclinical studies and translational studies, obtaining biopsies and peripheral blood from patients treated with checkpoint inhibitors, and then developing models that recapitulate the clinical phenotypes. There's a whole range of mechanisms that are still being studied, and we're really in our infancy there. We really don't know the mechanism why these toxicities happen, other than the very basics of removing immune homeostasis. But why individual patients get different side effects, completely poorly understood, and then specific mechanisms as well, just not very well understood. And then we're still also in our infancy of understanding these toxicities. These are really kind of de novo novel clinical syndromes. These are very different from any other syndrome that we see. They've got significant similarities to autoimmune diseases that patients get, but they're also very different as well. So there's still a lot of work to be done to give better treatments and better care to patients. And so we're trying, as I hope I've shown so far, we're trying to tackle this in a multidisciplinary way, trying to integrate the clinical, the translational, and the basic science findings, and then get other people involved from other disciplines. I'm an oncologist, and so I don't know all that much about the heart or the kidneys or the skin, to be honest. And so it's very nice to have collaborators in some of these spaces to help us with the clinical manifestations, but then also provide their expertise in terms of characterizing these syndromes at a translational and basic science level. So we've got this group of called VPoint, Vanderbilt Program for Optimizing Immuno-Oncology Therapy, that's been a lot of fun to be involved with. So to wrap up, I'd like to thank my collaborators, my funders, mentors, thank Dr. Shing for the kind invitation, and I'd be very happy to take any questions.
That's a wonderful talk. So I'm still waiting for questions coming in. So there is one question from Anthony Lamantia, who is the director of the Center for Neurobiology Research. So I guess you probably already have the answer to this question. So he asked, is there any age dependence in the toxicity responses?
Yeah, it's a great question. If you look at all toxicities, if you just look at sort of any grade toxicities and high grade toxicities, you actually see pretty similar in younger versus older patients. But as the one slide showed, there does seem to be a bit of a difference from an organs involved from a pattern of toxicity. And it's always a little hard to know, what's the mechanism there, but there does seem to be a real difference. More liver, more GI toxicity in younger patients, more skin, joint, perhaps lung toxicity in older patients. And if I had to hypothesize that, I'd probably say, accumulated, additional mutations in the skin or organ damage in the joints, et cetera. That does happen with age. I think the liver in younger patients, and we've actually have a second cohort that really recapitulates that there's a dramatic difference in liver toxicity in younger patients, especially if you look at the very youngest, so the under 40 group. There's a lot of liver toxicity in that group. So I think that's kind of an interesting finding that I think would be very, very fascinating to study the mechanism there. So sorry, to answer the other part of the question, as far as response, yeah, it's a great question. So one of the more high-profile individuals to get immune checkpoint inhibitors recently was former President Jimmy Carter. He had metastatic melanoma and he received pembrolizumab, and that was about 6 years ago. So he's a good object lesson of patients, how well patients can do with checkpoint inhibitors. They can have such long-term responses. And so we've looked, and others have looked as well, to see is there a big difference. And there doesn't seem to be a major difference in terms of response and survival by age. There may be a little bit worse with sort of the extremes of age, the 80-plus population. And there also may be a little bit less good of a response in the very younger patients, but whether that could be related to the patient's mutation burden. So there's data that suggests that the more highly mutated a tumor is, the better it will respond to checkpoint inhibitors. And so there's some might hypothesize that the younger a patient is, the less in general the less mutations a patient's tumor has, and perhaps the worse the response. But they're relatively subtle associations. It's certainly not it's not double the response rate or anything like that.
So how can you could you predict the toxicities, possible toxicities?
Yeah, so in a great question. In a population, we can. So we can say that with a single agent anti-PD-1 therapy or with combination therapy, we can say X% is going to get this side effect and this side effect and this side effect, and we can do that pretty reliably because there's been very similar numbers across different studies, and that's pretty predictable. Now, for an individual patient, it's completely unpredictable. It's there's essentially zero good predictors for who's going to experience what kind of toxicity. So it's definitely random from our standpoint. So we're trying to do a number of different things like HLA phenotype, HLA typing, and SNP arrays to see if different polymorphisms might predict, to see if there's pre-existing autoantibodies that might predict. So we're trying to look at this from a molecular level as well.
There is a question from Robert Gordy, who is our director of Center for Vascular and Heart Research. And he asked, doxorubicin also causes cardiotoxicity. Are there any parallels with the untoward effects of immune checkpoint inhibitors? What are your thoughts on the mitigating the cardiotoxic effects of checkpoint inhibitors? There is some evidence that cardiotoxicity may be mitigated by exosome delivery, for example.
Yeah, it's a great question. I think it's, at least as far as our understanding and my understanding, that you have very different mechanisms for doxorubicin toxicity versus, that's more of a direct muscle injury, although that's certainly not my area. Whereas checkpoint inhibitor is really an inflammatory disorder where you're actually, inducing T cells to attack the heart. Now, I think where this question also becomes very interesting is, as we start to use these therapies in, say, breast cancer, or we start to use these therapies in combination with, say, VEGF inhibitors, which there's a number of approved regimens. Will we start to see synergistic toxicities? Are we going to see that the VEGF effect is compounded by the checkpoint inhibitors and it causes increased inflammation or other types of synergy? And I would say we've seen a little bit of evidence of that. It seems like if you combine, for example, pembrolizumab plus axitinib, which is a VEGF tyrosine kinase inhibitor, you do see probably a little bit of increased cardiac toxicity, but it's certainly not dramatically increased. It's probably a bit increased what you'd expect from either one alone. Now, to the question of mitigation, so there's several different studies trying to do different mitigating strategies. So for one example is that there's a combination of ipilimumab, nivolumab, and tocilizumab, which is an anti-IL-6. There's some data that suggests that IL-6 preferentially mitigates toxicities compared to anti-tumor responses, and so those types of approaches may be very interesting. But at this point, we don't have anything in the clinic to mitigate those toxicities.
There is a question from Joseph Owens. He asked, I was wondering if there is any correlation between the location of the tumor metastasis and the types of ICI toxicities observed.
Yeah, it's a great question. So that specifically has not been studied. We and others have looked at whether the underlying tumor affects the type of toxicity, so lung cancer versus melanoma and so forth. There doesn't seem to be a major pattern there. Lung cancer may be associated with increased pneumonitis, inflammation of the lungs, but I think there also could be some diagnostic bias. These lung cancer patients have a lot going on in their lungs, pneumonia and other pleural effusions and so forth. So I wonder if there's an overdiagnosis there. Now, one really interesting finding that's been reproduced is that patients with metastatic thymoma, which is a rare cancer of the thymus, those patients, about half of those patients develop myositis or myocarditis, which is obviously much higher than any other tumor type, which actually may, I guess, bridge into the next question a little bit as well.
There is one last question from Padmaya Melody. He asked, have you used CPI in patients with myasthenia gravis or solid organ transplant patients?
Yeah, so the reason I mentioned that is a good bridge to that question is that patients with thymoma, that rare thymus cancer, have a high rate of myasthenia gravis, and those often flare when that's used. So I've used it in a few patients with myasthenia gravis. I think out of the 3 or 4 I've used it, I think half have flared and half have responded. So it's something you can do, but you just have to watch them really closely. So obviously myasthenia is a potentially life-threatening autoimmune disease, and so it's very different from something like psoriasis, where you're not that worried about the patient having a psoriasis flare. versus a myasthenia gravis flare. So we've used it, I would say, very cautiously, and have had some toxicity from it for sure. Now, solid organ, I briefly mentioned it earlier in the talk, is that we've used it in a handful of patients, and a lot of these patients do they do reject their organ. So it's something you have to be very, very cautious with. Really talk with the patient about because sometimes there is a patient that has, say, a kidney transplant, metastatic disease that has no other treatment options, and you may bite the bullet and say, well, we're going to take the risk and do it. Especially if they've got a backup plan like dialysis. It's not so easy when it's a heart transplant or a liver transplant where or fulminant rejection would result in death. And so that's a bigger, a very tough situation when a patient with a liver transplant or something comes into the clinic with metastatic melanoma. You have to weigh those kind of options. But we've bitten the bullet a couple times and done it, and it's about 50-50 whether they reject the organ. So it's a high risk situation.
Great. So let's thank Dr. Johnson for his wonderful talk.
Well, thanks for the opportunity. Take care, everyone.
Thanks.